everyone for joining us on this interesting day. I'm here today with Dr. Jane Schulz, a subspecialist who deals with women's urinary and gynecologic surgery. She's also a teacher in obstetrics and gynecology in the Faculty of Medicine at the University of Alberta. She's attempted to solve the delays in women's health care generally and surgery, urogenital surgery in particular, for the last 5 years, and unsuccessfully so. She's met with a minister, she's met with other members of the Alberta Health Services, and is now here to call for urgent action on serious healthcare deficiencies, women's healthcare deficiencies. So I'll turn it over to Dr. Schulz, and she'll have a few comments, and then we're open to questions.
Thank you everyone for coming. We just wanted to raise concerns about access to healthcare for women in this province. It takes 2 to 3 years to see a urogynecologist, and then a further 6 to 12 months to get surgery for your urogynecologic problem. These are women that are suffering with pelvic floor problems, pelvic organ prolapse, and urinary incontinence. This can often lead to urinary tract infections, urosepsis, inability to work, marked discomfort, increased risk of falls and fractures, and increased risk of nursing home institutionalization. We have approached the administration on many levels and have not yet been able to resolve these waitlist issues. We have had a third death on our recent, I was recently made aware of a third death on our urosurgical waitlist, and this was of urosepsis, which is urinary tract infection with bloodborne infection. There is a possibility now that this may be linked to their wait time on the surgical list. We've been trying to recruit another urogynecologist to Edmonton for over 5 years, and this has been very difficult. And our concern at this point with the current political climate is that it's going to be even more difficult to recruit these subspecialists to Alberta. The other component of this is that urogynecologists have academic interest and are involved in research and teaching in the Department of Obstetrics and Gynecology at the Faculty of Medicine. With the current cuts to post-secondary education, this also impacts our ability to recruit, because these physicians like to teach our future healthcare providers. Our Department of Obstetrics and Gynecology is currently operating at a bare minimum of academic staff, and if we face these cuts and are unable to recruit further, it impacts the ability of the medical school to function, as obstetrics and gynecology is a core specialty of the medical school.
Any questions?
Well, there's lots of questions.
Lots of questions.
You said the third death, Dr. Schulz. That implies that there were 2 more. Is this a recent phenomenon? Is it? Can you tell me just a little bit about that?
The 3 deaths have occurred of urosepsis over the last 12 months. These women are often elderly and have other medical conditions, so it is somewhat complex. However, with the 3rd death recently brought to my attention, it does raise red flags as to whether this may be linked to them having to wait on the surgical list with their prolapse and urinary incontinence, which we know do put them at risk of urinary infection.
Why is the wait list so long?
It is complicated, but there are multiple reasons. The main reason, however, is having physicians in the subspecialty area available to treat these patients, and also access to operating room time.
Dr. Schulz, let me start by saying thank you for stepping forward and talking about this. Can you tell us why has it been so difficult for you to recruit somebody in this specialty?
There are very few people that train in this field. It is a complicated patient area that requires additional levels of training. However, with the environment in Alberta and concerns about the toxic environment towards physicians, it is a concern in terms of recruiting.
And forgive me, I'm a bit of a medical illiterate. I don't have any scientific background or medical background at all. Can you explain just in really basic terms, you use terms like prolapse and big words, medical words that I don't really understand. Can you sort of explain to me, just in really basic terms, what these women are suffering from?
So these problems that these women have often occur after having had children, but can occur in other women. 1 in 4 women will have bladder leakage, so they leak from their bladder in their lifetime. And 50% of women, so 1 in 2 women, will have pelvic organ prolapse, which means their uterus, their bladder, or their rectum are falling out of the vagina like a hernia, essentially. And this leads to significant discomfort, difficulty with urinary tract function, and as I mentioned, risk of urinary infection.
This probably happens to older women, I would think. Yeah.
It does impact elderly women more. We certainly see it more in the elderly population, especially after the menopause. However, we see women anywhere from 18 to 105 in our clinic.
And I suppose the incident rate is just going to get higher with an aging population as well, too.
Exactly. So this is a concern as our population is aging and access to care becomes more difficult. Unfortunately, these women also will not speak up or advocate for themselves because it's a very embarrassing issue.
You were talking about the long waiting list. Do you have any sense of how many people are on there? And with your current staffing, how many operations can you do per day, per week? Or
So that's a little bit of a complicated question because sometimes the surgeries are an hour and sometimes they're 6 hours. On average, we probably do between 4 and 6 surgeries a week. The 2 urogynecologists we have in Edmonton, we do a lot of our surgeries together to try and decrease the operating time because one of us can work from abdominally and one of us can work from the vaginal aspect. We operate 2 days a week and usually do between 4 and 6 surgeries a week. Sorry, what was the other question?
and what would be needed to shorten that waiting list that's getting long?
Right. So we're very fortunate in Edmonton in that we do have a multidisciplinary clinic. So we have streamlined things quite significantly and improved efficiencies. And we have worked with Alberta Health Services to improve our efficiencies in the clinic by 20%. All our patients, the majority of our patients are seen by a specialist nurse first. And we have several of those at the Lois Hole Hospital, at the Misericordia Hospital, and at the Grey Nuns Hospital, and they do the initial assessment. Often these patients can be managed non-surgically. And we also have a family physician, physiotherapist, and a nurse practitioner that work with us. Then there are the 2 urogynecologists, 2 urologists, and a colorectal surgeon that can help manage the surgical issues. So at this point, our main restriction to reducing wait lists is having additional subspecialists, so additional urogynecologists.
Dr. Schulz, you said that you had gone to the government several times to try to address this issue. Can you give us a little bit more detail about what you've done over the past few years to try to address this and what the response has been from the government?
So we have gone to the Health Administration, Alberta Health Services, on a number of occasions. And they, in general, are supportive, definitely at our hospital level, in terms of the women's health program. However, often as you get to a higher level in terms of providing the resources and the funding, it sometimes becomes an obstruction. This process with Dr. Swann started probably just over a year ago. I had actually contacted my MLA at the time, which was Kevin Taft. He'd been our MLA for several years, and just expressed concerns about our abilities to recruit and the wait times and the access to care for patients. Mr. Taft put me in contact with Dr. Swann as he was the liberal health specialist. And we met at that time, and Dr. Swann was able to facilitate a meeting between Minister Horn and Dr. Flood and myself. And we did meet with Minister Horn in approximately February of 2012. And he was sympathetic to our concerns and acknowledged that it was a concern and the wait times were an issue. We then went on to have applicants last year for the position. And when it came to making an offer for these applicants, this was probably in April of last year, we then ran into problems again with promising the operating room time and the resources. So I did contact the minister's office again at that time, and at that point he said he couldn't do anything further and he withdrew any further support at that time. We had also written to the Premier, and she is aware of the problem, but she had delegated it to Minister Horn.
Dr. Schulz, how does this make you feel? I mean, you're a medical professional, and it sounds like you're trying to broker deals to try and get resources just to treat your patients.
It's frustrating as a medical professional because for physicians, patient care comes first. And the main thing we're focusing on is access to care and wait times for these poor ladies that are waiting with these problems. So it's very frustrating and makes me concerned and sad that we have significant morbidity and some now mortality on our waiting list.
It's obviously a very big decision to decide to, you know, hold a press conference and go public about this. What was the final straw? What made you do this today?
The deaths on the surgical wait list was what prompted me speaking to Dr. Swann again. And just our frustrations and no progress essentially over the year, that we had 2 physicians that we did offer jobs to and they did not want to come to Edmonton, and just our difficulties in recruiting, and now the current political environment, which is somewhat toxic towards physicians, and also the concerns at the post-secondary level with cuts and ability to train future people to provide health care for women.
Has there been a reduction in surgical time as well too? I had heard something about it, that there was an across-the-board reduction. What can you tell me about that?
So there is some impact on operating room availability across the board. In women's health, I know, for example, next week in spring break, we're down to just 1 emergency oncology room for the week, whereas normally we continue to function through spring break, and my understanding is there will be further cutbacks to operating room time in the summer. However, I do have to say at the ALEC, they've been very proactive for our program and have preferentially provided us surgical operating time because of our wait lists. And sometimes if we take additional surgical time, then I have to cancel a clinic, and patients have been waiting 3 years to see me, so it becomes a difficult balancing act of, do I cancel the patient visit and make them wait another 6 months to do additional surgeries, or do I decline that operating room time? It's a bit of a difficult balance.
Waiting 3 years to see you, what could happen to a patient's condition without being seen by a specialist over a 3-year period?
It often markedly deteriorates over that period, and women are suffering with these problems and unable to do their normal activities or work or function, and often they end up in hospital or in our emergency rooms waiting to see us.
You said the wait list is 2 to 3 years and then 6 to 12 months to get surgery. But did you say how many people are actually on the wait list at this point?
I think it's approximately 1,000 patients on our wait list for the clinic at the moment. We see about 11,000 patients per year in the Urogynecology clinic in Edmonton, and Calgary has similar numbers and similar wait lists.
So 1,000 people waiting to see you in Edmonton, and 1,000 more people, women, waiting to see somebody in Calgary.
And we get approximately 20 to 30 new referrals a day.
Do you have any thoughts about if this is, I don't know how to put this, but is this being ignored because it's a women's issue? I don't know if that's fair, but I'll throw that out there anyway.
It's hard to comment on that, but certainly we have had issues in voicing concerns of women in the past. And even when we've done media events at the Royal ALEC, unfortunately they often want a patient face to go with the problem, and our women are unwilling or unable to appear publicly because they're a high school teacher, or they work at the IGA, or they work at a bank and they're a bank manager, and they're not willing to go out publicly and say, I pee my pants, I have my internal organs falling out of my vagina. They are not willing to do that. So unfortunately it is an underrepresented issue.
Can you tell us anything about the patients who did die while on the waiting list? I realize there's confidentiality issues, but generally you said they're elderly women?
They're elderly women, they were over 60 and they passed away. The cause of death that I was notified of was urosepsis, which means they had a bad urinary tract infection which then spread into their bloodstream and caused their death according to the notice of death.
Were they from, where in the province were they from?
I cannot remember exactly. We provide care for women from Red Deer North. We do also receive referrals from Northwest Territories, Northern BC, and parts of Saskatchewan.
And David, what does this tell you about the progress that has or has not been made with regard to waitlist?
Well, it very clearly says that we're not making progress on this particular area, very definitely. It may be that we are doing better in terms of hips and knees and cardiovascular surgery, but in terms of women's health, this doesn't seem to be a priority for this government.
Can I just go back, this is maybe a bit of a technical question, but when you were talking about the reasons that the folks won't, I don't know the name of the specialty, I'll get it right in my story though, don't worry. That when it came time to make the offer, it was the promise of operating room time couldn't be kept and resources couldn't be kept, and of course there's the academic component. Is the cost of the physician an issue for the government? I mean, like the salary?
The funding?
The funding for the salary, is that also an issue when you say resources?
It's not been brought up as a specific issue. It's more the whole package, including clinic time and beds in the hospital and operating room resources that comes as part of the package. I don't purport to be any kind of expert in terms of administration or economics of health, so at my level, it's just advocating for women and providing an additional subspecialist to provide care for them. And we've had significant blocks and difficulties in recruiting.
Okay.
My understanding is, from Alberta Health Services, that we still do currently have a vacant position that I am being told would be resourced if we can recruit someone. However, I'm a little bit uncertain, and there's also the university position linked to this as it currently stands, and I'm unsure if that will still be maintained. But my more of a concern is just the environment in the province, and it really is not appealing for people to come here at the present time.
Are all your surgical procedures done at the Lois Hole Hospital?
They are, yes.
And is there a name for your clinic?
Our clinic is the Women's Health Clinic, the Urogynecologist Clinic at the Lois Hole Hospital.
You were talking about a lot of different conditions. Could you explain to us really simply again how it could affect your quality of life during when you're on a wait list or when you can't see a specialist?
Right, so a lot of these women have their uterus or their womb hanging out from their vagina, and it can go down to about 10 centimeters outside their vagina. So it's like a big mass or a lump hanging out of their vagina. So often when they present to us, they're afraid they have a tumor or a cancer because they have this mass hanging out of their vagina. And they often present to emergency and say, I have a mass, I have a tumor, but it's actually their prolapse. Then they're unable to empty their bladder properly. They're at higher risk of getting infection, and they often have associated leakage from their bladder and bowel, so they have to wear diapers. There's a lot of literature showing that quality of life for these women is markedly reduced. They put it on an equivalent level to suffering from chronic asthma or chronic diabetes in terms of the impact on quality of life. It leads to increased risk of nursing home admission, hospitalization, urinary tract infection, skin breakdown, loss of employment time, and increased dependence on caregivers. And there's also a link to higher risk of depression in these women as well.
Is there any pain associated with that part of the condition?
They have significant pain and discomfort often associated with this, yes.
Surgically, how successful is the treatment if you have surgery?
So it depends on the type of problem, but success rates usually run between 80 and 95% in terms of curing these problems.
And are they restored back to continence?
Yes. about 85–90% of the time they're restored back to full continence and no longer have to wear pads or diapers and can go back to doing all their normal activities.
Is there anything we didn't ask you that we should have, anything you had hoped to talk about that we didn't cover?
That covers everything. Our big thing is, yeah, access to care for women and these poor women suffering and dying on our wait lists.
Perfect.
Thanks
Did
very
you have
much.
anything to